Hospitals across the country are struggling to maintain coverage in essential specialties: anesthesiology, radiology, emergency medicine, and certain surgical subspecialties. In many communities, hospitals are paying significant stipends just to keep 24/7 coverage in place. At the same time, reimbursement hasn't kept pace with inflation or with operating costs. The gap between what physicians collect professionally and what it actually costs to staff hospital services continues to widen. Most conversations blame workforce shortages or payer rates. Those explanations are familiar and they do matter, but there's also a structural issue that rarely gets discussed. Federal law largely prohibits new or expanded physician ownership of hospitals. The Stark Law restricts physicians from owning hospitals to which they refer patients. The historical concern was overutilization, the idea that ownership would encourage unnecessary services. But here's the question: does that rationale still hold in today's environment? Hospitals now directly employ large numbers of physicians. Those employed physicians generate admissions, procedures, imaging, and ancillary revenue for the hospital. The financial alignment is real and intentional. It's regulated, yeah, but it's permitted. So if financial alignment between hospitals and physicians is already allowed through employment, why is ownership uniquely prohibited? Meanwhile, hospitals are already subsidizing many hospital-based specialties. In anesthesiology and radiology especially, professional reimbursement often doesn't cover the cost of required staffing. Hospitals fill the gap with ongoing coverage support payments. That's not a true market equilibrium. It's a patchwork subsidy model. Ownership wouldn't magically solve the problem, but it would change the alignment. It would allow physicians to share in facility level performance rather than relying solely on professional fees and stipends. It could encourage longer term commitments to institutions. It could create shared risk instead of one-sided financial support. Critics will say that ownership increases the risk of overutilization. Financial incentives do influence behavior, but incentives already exist under employment models and productivity-based compensation. And today we have fraud and abuse enforcement, payer oversight, quality reporting, and value-based reimbursement structures designed to police inappropriate conduct. At the same time, hospitals are expected to maintain 24/7 coverage, sustain unprofitable services, and operate with shrinking margins. Physicians in these specialties face declining real reimbursement, increasing liability exposure, and lifestyle pressures. The shortage isn't just about training more doctors, it's about how the system is financed and structured. Ownership isn't a cure-all, but prohibiting it removes one potential alignment tool before it can even be evaluated. This isn't a call to eliminate all guardrails. It's a call to revisit whether a categorical prohibition still makes sense in a healthcare landscape defined by workforce instability and financial strain. The question isn't whether physician ownership is inherently good or bad. The question is whether banning it outright still serves patients, or whether it may be limiting solutions to a structural problem that isn't going away. That's a conversation worth having.